Hi, everyone. Welcome back. I'm Dr. Samantha, the maternity mentor, and I'm here for another one of my live Q&A sessions. I hold these every Monday at 9 p.m. Eastern Standard Time. This is a chance for you guys to interact with me and to put any questions that you have into the chat live. This is also a chance for me to answer any questions that you guys have put onto the videos on the channel. Please remember, share the channel with your friends and family. Follow us on Facebook, Instagram, and Twitter for additional content. Those will be linked into the description. We are here and we have been approved to be a part of the YouTube Health platform, which is very exciting. What this means is that YouTube has taken the time to go ahead and make sure that providers who say they are healthcare providers are actual healthcare providers and that they've been vetted and that their content is accurate. So that's really exciting for us. Please remember to like and subscribe to the channel. For those of you guys who don't know, subscribing to a channel is really, really, really important and helpful for content creators. It allows us to stay on and do stuff like this. So if you can subscribe, tell anybody you know to subscribe, I would really appreciate that. That really, really helps me out. And of course, hit the notification bell so you can get notified of our latest content. And for those of you who stick around until the end, we will give you a sneak peek at tomorrow's video. So while you guys are coming in, remember, please feel free to put any questions you have into the chat. I always like to start with some of the questions that we got on some of the videos this week. So I'm going to go ahead and get started. So we're going to start up with antibiotics this week. We had a lot of antibiotic questions that came up, and I think this is a very important subject. We had some very interesting ones this week. So let me start out with the following question. I was prescribed metronidazole for BV, which is bacterial vaginosis, and I'm in the beginning of my second trimester. I'm supposed to take 500 milligrams 3 times a day for 10 days. I don't feel like it's safe. Please let me know your opinion. So this is a great place to start. And I actually love the 3 antibiotic questions that we have. So antibiotics are designed to kill bacteria. They do not work for viruses. They do not work for funguses. They do not work for yeast. They work for bacteria only. Now, many of us get a cold, we go to the doctor, we feel like all awful, and sometimes the doctor will say, oh, it's viral, go home. It's not going to work with an antibiotic. And sometimes we'll get an antibiotic and we don't even feel better because it was a virus all along. When it comes to vaginal infections, though, and actually urinary infections, the nice thing is we can test it very easily. When you have like a cold, like a sinusitis or something, you can't always tell what it is. With a vaginal infection, it's very easy. When you come in, we go ahead and we swab you. We use a sterile swab. We collect some of the discharge that we see coming from the vagina, or we take a urine sample and we send it off to a lab and we look to see what's there. And if you have a bacterial infection, we're going to prescribe an antibiotic. Now, it is extremely important that you take your antibiotics if you've been diagnosed with a bacterial infection. Bacterial infections, including urinary tract infections, are one of the top causes for preterm labor. And a lot of people think, oh, but I get urinary tract infections all the time. When you're pregnant, you are immunocompromised. You cannot fight off infections the way you normally would. Now, the other thing is the infection can spread very quickly into the uterus and it can affect the baby. So it's extremely important that you take it. Now, when you do take the medication, you have to take it, all of it, as prescribed. You cannot stop in the middle. Antibiotics are amazing because they help you feel better fast. So like within a day or two, you're feeling amazing. But the problem is it hasn't killed off all the bacteria. And the bacteria that are left, they can figure out a defense against the antibiotic we just gave you. So if you stop and wait, a couple of days later, you're sick again, you try to take the same medication and it won't work. That's antibiotic resistance, okay? It's very, very important you understand that. So if you commit to an antibiotic, you need to take it all. Now, one of the things that this question highlights is I'm in my second trimester. This is a big thing when it comes to any type of medication used during pregnancy. The first trimester, there's a lot of organ development and other things going on. And so a lot of people get really nervous about taking a medication because they're worried about birth defects. And that is a valid concern, which is why you always want to check on the safety of the medication that's been prescribed to you. However, when it comes to antibiotics, most of them are very safe for pregnancy, including the first trimester. And if we're trying to prevent and treat an infection that's there, we may actually prevent a miscarriage by doing so. So it's extremely important to be treated. Now, bacterial vaginosis is a medication. Is a infection. It's not sexually transmitted, but your partner may sometimes have it. It's basically caused by like a little bit of a pH imbalance that allows natural bacteria to overgrow. This is best treated with metronidazole. That is the top antibiotic for this particular infection. And that particular medication is safe for pregnancy, including first trimester. Now, I'm going to answer my other two. Antibiotic questions, and I'm going to get to the 2 questions I see in the chat. So I promise I'm going to be right with you guys. So the second question was, I'm so anxious and stressed because I'm 6 weeks pregnant and I was diagnosed with sinusitis and I'm on antibiotics augmented. So this is a great example of, are you sure you need an antibiotic? Sinusitis is usually an infection of the sinuses. It's often the common cold. A common cold is usually 9 times out of 10 a virus. It is not a bacteria. So when you're talking about a sinusitis, you don't want to take an antibiotic if you're not sure that it's going to treat the infection. So you want to ask how your healthcare provider came to that determination that they wanted to give you that. Now, if they drew blood and your white blood cells were really high, well, that's a sign that an antibiotic might work. But you definitely want to ask what's going on and whether it's warranted to take antibiotics, whether you could wait a couple days and see if it'll go away, that kind of thing. Augmentin is safe for use during pregnancy. The animal studies that we've seen show that even when animals were given 4.9 times the human dose, there was no evidence of any type of birth defects, which again is the biggest thing that people worry about in the first trimester. So this should be a medication that's safe for use during your pregnancy. If you have a bacterial infection, you definitely need to take your antibiotics. Now, the last question was, I got prescribed cephalexin today for a possible infection in my fingernail bed from a dog nip. The prescription is 250 milligrams twice a day for 5 days. I'm nervous about taking any medication during the pregnancy because I don't like the idea of the baby getting it into their system. So, animal bites are particularly tricky. For any of you guys that may be dealing with an animal bite or know somebody who has, I would 1,000 times recommend that if you've been given an antibiotic, you take it. Animal bites, if left untreated, can cause sepsis. This is a system-wide blood infection that can cause organ failure. If you develop sepsis, this is going to put your baby's life in danger. Animal bite infections are extremely difficult to take care of. I actually have 2 current patients who both required more than a month of IV antibiotics to take care of their animal bite infections. Animals have a lot of bacteria in their mouth. That bacteria is normal for the animal, so it doesn't affect them at all. But for us, this is not bacteria we normally are exposed to like every day, all day long. When you get a puncture wound that allows that bacteria that you're normally not exposed to get into your bloodstream, this can cause massive infection. And remember, these infections can cross the placenta. If you guys didn't know that, these infections can cross the placenta. A really good example of this is toxoplasmosis. So toxoplasmosis is commonly found in cat feces. And so that's why pregnant women are not supposed to like clean and change litter boxes. That is supposed to be done by somebody else, because just being around that litter, you can get a toxoplasmosis infection, and this can cause miscarriage, stillbirth, or preterm birth. So you guys need to be really careful about animal bacteria. You wash your hands very well. Another good example, we have bearded dragon. Bearded dragons are lizards. Lizards often have salmonella. Salmonella is another infection that you can get, and you're immunocompromised. If you're immunocompromised, a casual contact with something that normally wouldn't be a big deal is a huge deal during pregnancy. So again, you need to make sure you're washing your hands and stuff. Now, do you need to isolate? No, you can still go out and do your thing, but you need to be aware of what you're doing and make sure you stay really healthy. To answer this person about cephalexin, cephalexin is also safe for use during pregnancy. Hi, Kyle. For a mom, how would a midwife know if a mom was in labor? So this is a good question. We do have a video on the 10 stages of labor. The biggest thing is cervical change. Ultimately, it's cervical change. So you have a uterus, and at the bottom, you have the cervix, okay? And the cervix should look just like my fingers. It's long, it's thick, and it's closed. And for those of you guys who are wondering what the mucus plug is, so you see, this actually almost perfectly represents a cervix, and in some ways, it actually feels like a cervix, okay? So your cervix has to open to allow a baby's head to come down, right? So it can't be like closed. So this little tiny opening, that's where the mucus plug is. And all it is a line of mucus that tries to seal this shut so that stuff can't go up into the uterus, okay? So when you start to dilate, that mucus plug falls out, okay? So now we've got our uterus. I'm going to flip my fingers. This is your cervix. When you're having contractions, what happens is they start to pull at this cervix, and the cervix does exactly what my fingers are doing. So this is effacement, okay? You go from thick to thin. This is dilation, opening. And eventually you get to the point that you can't feel a cervix at all. All you feel is a head. You're fully dilated, okay? The last thing people hear when they're in labor is +1, +2, -1, -2. That's how high up or high down the head is, okay? That's all that number is. So the biggest thing we look for to know if somebody's in labor is cervical change. Now, you might be thinking contractions. So you can have an ineffective contraction pattern and be in labor. If you are making cervical change, you are in labor because ultimately the cervix opens and you have a baby. This is why some women will come in and they'll be 6 centimeters dilated at 17 weeks pregnant and they're about to deliver and they didn't even know it, okay? Because they had been having silent contractions. Because contractions ultimately are what causes this cervical change, okay? Now, once we look at cervical change, the only other thing we're really looking for usually is contractions. You may have some cramping. A lot of people mistake backaches as like a backache, and it's really contractions. And you may have some bleeding. Now, there are a whole bunch more. You can look at the video, but the biggest thing, again, is cervical change. Adanu, I hope I said that right. My daughter has been suffering from Joubert syndrome. Which test can I do in pregnancy that my second baby is free from Joubert syndrome? Thank you for asking this, and I did see your question. So she asked the question on the video, and this is awesome that she's here live to ask the question, and this is really great. And then I had looked into this a little bit more. So Joubert syndrome is a genetic condition that it affects how the baby's brain develops. It's extremely rare, and it actually affects 35 genes that a baby might have. And so from what I'm gathering from the question, which is very understandable, having had one child with this, she wants to know if you can go ahead and test for this during the pregnancy, and you cannot. So the way that Joubert syndrome is usually diagnosed is by MRI. So this is a scan of the baby's brain. It is most of the time diagnosed after you've delivered, when they're starting to see symptoms of this with the baby. Now, there have been some cases that were diagnosed while a mom was still pregnant. And the way that was done was during an ultrasound. There are standard ultrasounds that are done to check baby's anatomy. That's the structures of the baby and how they look. Some abnormalities were seen in the brain. For those of you who don't know, you can have an MRI while you are pregnant. In fact, it's very common. And so these cases that were diagnosed while a mom was still pregnant, they did an MRI to check the baby's brain. Once certain structures were noticed to be abnormal, what they then did was they tested the parents. So because you have a child with Joubert syndrome, this means that most likely it was either spontaneous or you and your partner both have the recessive gene. If the two of you have the recessive gene, there's a 25% chance that your next child could have Joubert syndrome. So what you want to do is actually get tested prenatally before you get pregnant to see if you both have the gene. If you don't have the gene, this probably spontaneously happened, and there's nothing that you're going to be able to do other than to try to have a really healthy pregnancy. If you guys both have the recessive gene, then you can look in further with some high-risk doctors to see about genetic counseling and what you can do and what your options are. But as far as the regular kind of standard genetic screens, this is not something that's going to show up on amniocentesis. It's not something that's going to show up on a lot of different screens. And part of it's because it actually involves 35 separate genes. Okay. Thank you for asking that question. I think that was a very important question because a lot of people get really, really nervous about that kind of thing and wondering what genetic screens are going to show up and how it goes. Kyle, what happens if the mom cervix does not open? So if the mom's cervix does not open, you're having a C-section. That's the bottom line. That's why we have surgical intervention. Now, one of the things I'll tell you is I actually have a whole bunch of videos. Like I have a couple of videos, I think, on induction of labor. I know one of them was on Cervidil, which is one of my favorite medications for an induction of labor. Guys, in my opinion, the best inductions of labor take 3 or 4 days, okay? If you have not gone into natural labor, it is extremely beneficial for you to be able to have a longer induction. A lot of people are really antsy. Once this gets started, they just want to see the baby. And in fact, unfortunately, a lot of doctors and midwives are very antsy and they just want to see the baby. But if your cervix has not started to dilate naturally, if you haven't gone into labor naturally, then your body needs a chance to get kick-started into that. And if you have this thick cervix and you don't give it some kind of medication to like help thin that out, which is what Cervidil does, then you're going to end up with a C-section anyway. Now, one of the things you can do is there are natural ways to induce labor. And I actually think that might be going into the chat. If not, we'll put that into the chat. Some of the natural ways to induce labor can actually help to thin out that cervix ahead of time and make it more favorable should you need an induction. It will also help those Braxton Hicks contractions move along the progress of your cervix dilating. So Braxton Hicks contractions actually serve a purpose of helping to start to thin out the cervix over time. A Braxton Hicks contraction here or there, even at like 28 weeks, is not going to do full-on cervical dilation, but it certainly starts the process, and it should be a long, slow process. So that's what happens. So ultimately, you have a C-section. Jade, should a 35-year-old woman automatically be seen by a high-risk doctor because of her age? Yes, unfortunately, 35-year-old doctors. 35-year-old women are considered to be geriatric pregnancies. So it's one of those things that, unfortunately, yes, you are considered somebody who is high risk. I don't know if you think you should and you're not seeing a high risk doctor, or if they are telling you to do so and you don't think you are. Personally, I think everybody should be seen by a high risk doctor once. These guys are amazing. High-risk maternal fetal medicine doctors are absolutely amazing. I think that they're very straightforward. They are looking for problems. That sounds crazy that it's like, oh, but I don't want to have any problems. Exactly. So when they don't find anything, it's really great that you've kind of already been screened. They read their own ultrasounds. So one of the things you need to know is that when you're having an ultrasound in your OBGYN's office, yes, the midwife or the OBGYN may do some of the ultrasound and they may be looking at certain things, but they don't really truly read it. Okay. They kind of know what to look for, but they ultimately send it out to a radiologist to read. Now, maternal fetal medicine doctors also send theirs to a radiologist, but let me tell you something, they can read it. And they do stuff that your OBGYN isn't going to do. They look at stuff like the blood flow in the heart, the blood flow of the placenta, like pressures of the placenta, like really, really cool things. So it is really, really important in my opinion. Now, here's the other thing. Sometimes people are like, oh, but I don't know. Whenever you guys are referred to any specialist for any reason, and I'm going to tell you this applies to your family members, everybody you know. If you think you're going to need a specialist, always go and get established, because it's hardest to get the first appointment. Once you have the first appointment, getting follow-ups is easy. But like where I'm at in South Florida, it takes like 6 months to get into a neurologist, right? Oh, my cat's saying hi. So, when you get to a neurologist after 6 months, if you need like a follow-up, that can sometimes be in a week. So whenever you guys are referred to a specialist, I think it's really important that you go just to get established. Now, I see Jade saying, my doctor says I don't need it and I want to see one. I would push for it. I'm trying to be politically correct. Jade, if you are anything other than white, you should be absolutely pushing as hard as you can and making sure that your OBGYN is aware of all the disparity in maternal care if you are in the United States, and how women of other ethnicities besides my own are having worse care and should be getting a higher level of care. You are going to be more likely, if you are any other race besides white, you are at higher risk for diabetes, hypertension, preterm birth, any complication, you name it, it's there. So if you have that alone, you should just be saying, listen, I don't know why you're messing with my healthcare. I'm 35 years old. That's considered a geriatric pregnancy. Send me so I can get established. Because listen, that MFM is going to look at you, do a little assessment, and if there's nothing wrong, they're going to send you on your way. But 3 months into your pregnancy, if you're having an issue, they know who you are and they'll get you in. So I would absolutely heavily advocate for that. And even if you're white, you still, in my opinion, need to see an MFM. Okay, Kyle said, what happens if the baby gets stuck in the birth canal? So ultimately, I guess you would say a C-section. I do actually want to address this one a little bit further, right? So one of the reasons, what it's called usually if a baby gets stuck in the birth canal, is a shoulder dystocia. Usually what happens is the baby is too large and the pelvis doesn't open up wide enough and the baby gets lodged in. So we always hear about dilation. Dilation is just the cervix, okay? That's all that is. But throughout your pregnancy, if you guys have noticed, or you've noticed your friends or family, you know, we talk about women's noses getting bigger, their feet getting bigger and flatter, and then they start to do that waddle at the end. That's all because there's this hormone called relaxin that's going through your system, right? Now, relaxin is designed to relax all the joints, right? And so when it relaxes those joints, the whole reason why it's doing that is actually to relax the pelvis. This is also why a woman will start to widen, like at the, you know, in her pelvic area. And then sometimes you'll even see the drop right at the very end. And so that's because that all is opening up. When you go to deliver, the pelvis does open a little bit. The actual bones open a little bit to allow the baby to pass through in front of the spine. And so if a baby is too big, then the baby can get stuck. And that is called a shoulder dystocia. So if you have a shoulder dystocia, depending on the position of the baby, they're going to do a whole bunch of maneuvers to try to get the baby out very, very quickly. And one of the things that we sometimes will have to do is we will have to break the baby's clavicles. So we actually go ahead and we break this bone right here. And that sounds terrible, but a shoulder dystocia is a medical emergency. This is an emergency that can kill a baby. And we need to get a baby out fast. This is a time that a mom will most likely get an episiotomy. There's a whole bunch of maneuvers that we do, and we're doing this to save the baby's life. Once a baby's at a certain position in the birth canal, we cannot just push that baby back up. However, if the baby is not far enough down, we will do that. We will push the baby up and we will wheel you into a C-section. This all sounds really scary, right? Why am I saying this? Because I don't think it's said enough. If you have gestational diabetes, it is extremely important that you follow those diets, that you take your medication. Do not fight them when they ask you to take insulin. I personally think every single woman should take insulin if she has gestational diabetes. I do not believe in the diet-controlled gestational diabetic. What we are trying to do is prevent your baby from being too large, okay? We want to allow you to have a vaginal birth, and we want to prevent, amongst other things, a shoulder dystocia, okay? So when you are diagnosed with gestational diabetes, this is one of your biggest risks for this to happen. If you're being told by your doctors that your baby is very, very large and they are suggesting that you need a C-section, I am not telling you to just run into a C-section, but I am telling you not to ignore them. I am telling you to maybe ask for multiple ultrasounds, ask your risks and benefits, ask if you can try, ask when you should stop an induction and go straight into a C-section, ask all the questions. But one of the things when they are saying stuff like, if your baby's too big, it's dangerous to have a vaginal birth, this is what they're actually referring to. It is not common, but it does happen. Okay? Ultimately, though, we try to do a C-section before that happens, Kyle. Nancy, I'm trying to get pregnant as soon as possible. What do you recommend me to do? I'm 41 years old. Number one, see a maternal fetal medicine doctor pre-conception, okay? Again, these guys are amazing, and I personally think that they're really good for preconception counseling. Number two, go to see a reproductive endocrinologist. These are specialized women's health physicians that look at women's hormones to make sure your hormones are in line for you to get pregnant. Number three, healthy diet. Good prenatal vitamin. Make sure you guys are all taking prenatal vitamins. From age 15 to 48, in my opinion, women should be taking a prenatal vitamin. Number four, the keto diet. I personally think the keto diet is one of the best diets out there. I have been on it before. I should probably go on it again. It is a really good way of managing your sugar and giving you an overall really good, healthy body. So I really think that the keto diet is an excellent diet because it helps to balance out hormones and it helps to balance out how you absorb sugars and stuff like that. One of my favorite actual documentaries that I ever saw was The Magic Pill. And it was talking about like a low carb diet, not necessarily keto specifically. And when you start to talk about keto and how your body responds to it, this is how we used to eat when we were cavemen. Everything that you guys are doing when you're in this preconception, pregnancy, and postpartum period, this goes back to when we were first roaming the earth. I mean, this is how the human species survives. And ultimately, that's what we are. We are mammals. We are here and we are trying to survive. And genetically, at our core, how our bodies react, what we need to eat, how we sleep, and how we react emotionally to our partner and our children is all based on survival of our species, all of it. And so when you're talking about getting your body into the best health that it can be, when we were in caves, we ate primarily animal protein, healthy fats, and very low carbs. We were eating berries and different things like that. And it was all whole foods. We did not eat any wheat. We did not eat any of that stuff. It didn't exist. We also didn't eat potatoes, which is a big part of all of our diets, including my own. I mean, chips are great. But the thing is that they're not healthy. And we didn't eat potatoes because potatoes need to be farmed to eat them in large amounts. And so your body ultimately responds really well when you're eating a diet that's close to what our ancestors ate. And there's actually some evidence, and they're starting to do research on the idea of taking a keto diet and tweaking it to your ancestry. And what I mean by this is a lot of people do all those genetic tests like 23andMe and different things to find out what part of the world they're from. So let's say you find out that your primary background is in Norway. So most of your ancestors came from Norway. Well, a keto diet where your primary fats and proteins come from like the fish of the Nordic region, like salmon and stuff like that, is probably going to be better for you because genetically at your core, that's what you would have been eating back in the day. Now, somebody whose genetic background, say, comes from the Caribbean, right? So whereas most people for their carbs, they're going to be doing like berries, maybe some apples, stuff like that. And that for them is going to be absorbed really well and used properly. Somebody who's in the Caribbean might be able to eat sweeter, more carb-filled fruits like, say, mango, but they're processing it very differently because that's where their ancestry comes from. So I really do believe that that's one of the best ways to keep your body intact and really healthy to try to get pregnant. But honestly, I do think that getting in with some doctors and getting all of your blood work run is really, really important. Do some hold a mom's leg for birth? Yes, Kyle, that is very common. It just depends on what position you're in. Unfortunately, a lot of people are put into I think it's called the lithotomy position. It's basically you're on your back with your legs up in stirrups, which is really not the natural way to give birth. But because we put women into that position, we will sometimes like hold a mom's leg and pull them back a little bit during a natural birth to help open up the pelvis to allow for a baby to pass through. For any of you who are joining me, please feel free to put any questions you have into the chat. And for those of you who wait until the end, I'm going to give you a sneak peek at next week's video. I have a couple questions on bleeding. I'm 5 weeks bleeding. I'm 5 weeks and experiencing heavy bleeding and cramping. Is this a miscarriage? I called the OB and they told me to take another pregnancy test in 48 hours. The other one I had was I'm 3 months pregnant and experiencing brown blood spotting from time to time. Sometimes I feel nausea and I'm scared. What should I do? So I thought these two questions were really good, and I think they both bring up a couple of things. So I have a lot of videos on bleeding, so please check out some of them. I have a video on what you should ask in the emergency room so that they're checking you out properly. I have a video on colors of bleeding and all sorts of stuff. So the color, the brown that she refers to, that's old blood. That's a sign that you were bleeding and now you're not bleeding. And there's a lot of reasons why women will bleed in the first trimester. There's subchorionic hemorrhage. This is a little kind of pooling of blood underneath the placenta. Sometimes that will leak out. You can bleed from sex because the hormones for keeping a proper pregnancy thin out vaginal tissue. You might be bleeding from a hemorrhoid and not realize that that's what's actually going on. Now, what is most important is you need to get checked out. And that's why I put in, and the link is in the chat, the emergency room video. You need to get checked out. They need to rule out infection. They need to do an ultrasound and see what's going on. Can they see a subchorionic hemorrhage? Can they see a placenta issue? All these things are very important to assess bleeding. And just because you're bleeding during your first trimester does not mean that you are having a miscarriage. Now, the one question says that OB said to repeat a pregnancy test in a couple days. I actually really feel like this was, I think it was terrible. I think it was a terrible thing to say. So let me explain. When we take the P test that you get at home, we're looking for HCG. That is human chorionic gonadotropin. It is the hormone that says we're pregnant. And so when you pee on a stick, there's some of that hormone in your pee and it turns positive. Hey, you're pregnant because you have that there. Now, the thing is that can still be positive after a miscarriage. So we know a pregnancy is going well for a variety of reasons, but one of them can be a blood test. So when you go to the emergency room, one of the things I tell you is ask for the blood test. We take blood and we measure for the same thing, HCG. Normal HCG levels should double every 72 hours. So it should go up. If you are having a miscarriage, what they should be doing is drawing your HCG level, telling you to come back in 3 days and drawing the blood again. If the level is rising, that's a good sign. Even if you're still bleeding, that's a good sign that the pregnancy is going well. However, if the level is dropping, then that usually is a sign of miscarriage. But the thing is, let's say I go in and it's dropped from 10,000 to 7,000, right? That's probably not a good sign. However, you would still test positive on a urine pregnancy test. So if you are bleeding and they're telling you to retake a pregnancy test, ask them to do the blood test. That is what will really tell us from an HCG standpoint if a miscarriage is happening. Is short-term abdominal pain normal when bending over in the second trimester? Obviously, I would need a little bit more information, but I'm going to tell you, if it's a sharp stabbing pain that goes wham and then it's gone, that is probably round ligament pain, and that is unfortunately extremely normal. It is very cumbersome. There is no pain medication that will help it, and it is probably going to last for the rest of the pregnancy. I have a video on pelvic pain, so I definitely suggest that you check it out. What round ligament pain is this. So your uterus, right? It kind of hangs in the middle of your lower belly, right? And it's hanging there by these ligaments. So one of them is the round ligament. And ligaments are like basically like stretchy rubber bands that kind of attach it to your abdominal wall. Okay. I'm sure. So what happens is your uterus, when you are not pregnant, is like teeny, teeny, tiny, right? It's probably even smaller than that, right? But then when you get pregnant and that baby's growing, the uterus goes from this to like this. Okay. And then it's massive, it's full of blood, and it's heavy, and there's a big giant baby inside of it. So those little rubber bands that were holding your uterus in place are getting stretched over time. And what'll happen is if they're thinning out, and then what happens is if you like bend over, they can like twist, or they can do this, or they stretch all of a sudden. And if you imagine a rubber band, right, they're not going to snap, in case anybody's like having intrusive thoughts right now. But if you imagine a rubber band, have you ever seen somebody all of a sudden like stretch it really fast and then you're like, oh my God, is it going to break? That's kind of that tension is what you're feeling with that. So my guess is that is probably round ligament pain. Now, anybody who's having pain should get checked out. You're going to hear this over and over. Your doctors and midwives are being paid a lot of money to be on call 24/7. Call them, make them do an ultrasound, make sure everything is okay. However, I suspect that's what this is. Okay. I had a great question on vaginal discharge. It was like an awesome question. So I had a question for 46 days. My period was delayed. Then I had pinkish to brown discharge for 5 days when I wipe. I don't know if this discharge is pregnancy or PCOS. I think this is actually like bleeding. So I'm not sure what that is. But the other question I got, which was really good, and this, when I see the brown pinkish discharge, I just want you guys to know I'm not dismissing it, but discharge is very confusing for a lot of people. And so the other question I got was, I get sticky and sometimes get creamy discharge before and after my period, and I'm trying to get pregnant. So creamy discharge that's kind of like lotion. Okay, so it's kind of thick and creamy, and it's not cottage cheese because cottage cheese is usually a yeast infection, but it's like lotion, right? That's actually extremely normal, and it usually appears after your period until you ovulate. Ovulate is where your ovary releases an egg. So this is actually a very normal, healthy discharge that's just your body's way of kind of getting ready for everything. Now, during the time of ovulation, when things start to change, you will actually make this different kind of mucus. It's thin and it's sticky and it's sometimes jelly-like. And if you guys listen, I think everybody should check out their bodies, obviously with clean hands. But if you take your fingers and you get a little bit of this sticky discharge, if you take your fingers and you separate it, it will actually stretch across your fingers like egg whites. And you can actually go like this and it'll stick to both sides. That is fertile mucus. That clear, stretchy, sticky mucus is actually designed to help you get pregnant. It's usually a sign that you're ovulating, that you've released an egg, and it's designed to help the sperm get up. So it's kind of holding it on and guiding it up into the uterus for hopeful pregnancy. So those are two different types of discharge that are very normal and, are just part of everyday life for you. If you're not sure what's going on, you can always go to your healthcare provider and let them check you out. That's what they're there for. And what they'll do is they'll do like a little bit of they'll do a swab and they'll test it. But those both are very normal. We had a question on my miscarriages video, and it said, can cold sores cause miscarriages? So cold sores are caused by the herpes virus. So when you get them in the genital area, genital herpes, they show up as sores. And it looks different for everybody. Some people will equate it to being kind of like a burn type of thing, but it's like a sore. And this was a really good question because I think this makes a lot of people nervous because unfortunately genital herpes is becoming more and more common. So HSV, herpes simplex virus, is extremely common. From everything that they can tell from the research, it is not a cause of miscarriage. It's just something that's there and it really doesn't affect anything. However, HSV has been shown to cross the placenta and affect the placenta and can lead to late-term pregnancy losses. So this means you're in your third trimester and you have a stillbirth. So if you know that you have a history of HSV, what you're going to want to do is you're going to want to make sure that you're monitoring your baby. You're going to make sure you're attending all your prenatal care, and you want to have your healthcare provider teach you what a kick count is. And a kick count is a way for you to monitor the baby's movements. If you ever at any point in time do not think the baby is moving properly, you need to go straight to a hospital so that they can do an ultrasound and check the baby. But if somebody with a herpes simplex virus infection, you want to make sure that you're being very careful. Now, the final thing is, as long as you don't have active lesions, active sores at the time of birth, you can have a vaginal birth. That is okay with a herpes simplex virus mom. However, if there are active sores, it's an automatic C-section. Because herpes simplex virus, if a baby was to contract that, it can kill the baby. It's very difficult to treat. We have to send the babies to the NICUs. We give them IV antivirals and antibiotics, and we monitor them. But it is a very, very deadly condition for a baby. And so we want to try to avoid that. And it's a lot easier for a baby to develop a herpes infection if there's a vaginal birth with active sores. What happens if the rim does not go away for a birth? Oh, okay. I know what Kyle's talking about. Okay. So you go to, so it's 0 centimeters, which means you're closed, to 10 centimeters. 10 centimeters means nothing's there, right? So rim is like 9.5 centimeters. Basically, you can feel like the tiniest bit of the cervix. Sometimes we push through it. Sometimes that rim is not going to go away. And so we will just have you push. And usually that's enough. The baby just drops down a little bit and then you just dilate completely and we move on. All right. So we talked about bleeding during pregnancy. There's also bleeding after pregnancy, which can be called postpartum hemorrhage. So I have been bleeding for 8 weeks after delivery. My doctor gave me 21 days of hormonal pills, which stopped my periods. But after finishing these pills, I started bleeding again with heavy flow and clots. What can be done for the reason? I think she's saying for this. My doctor suggested a transvaginal ultrasound. So bleeding is something that's extremely important to deal with after you give birth. If you bleed too much, you have a hemorrhage. This can lead to anemia, and it can actually lead to major issues, including organ failure and death. So we very much need to address postpartum hemorrhage. One of the most common causes for bleeding longer term is actually retained placenta. So your placenta is the organ that feeds the baby. And so it's like this, and it's on the side of the uterine wall. And this side is a whole bunch of blood vessels, and the uterine wall is a whole bunch of blood vessels. And these guys intermix together because blood needs to go to and from the baby to transport nutrients to the baby and oxygen to the baby and take away carbon dioxide and toxins, right? Now, when you give birth to the baby, the placenta detaches. Now, if you guys get a chance to look at a placenta, it looks kind of like ground meat. Okay. So it's very like chunky on the side, and it looks like meat. And the thing is, it's not smooth. It's not like a smooth piece of paper. So a little tiny piece of that tissue can stay inside the uterine wall. Now, these are a whole bunch of open blood vessels, and these need to close. And the way that happens is the uterus contracts back down. And as the uterine wall is contracting back down, it puts pressure on those blood vessels, which shuts them off. You stop bleeding. If you have a little piece of tissue here, this can't do its job. So instead of it being tight, it's like looser. You see that? So we need to make sure all the tissue is out. Now, if that doesn't happen, you continue to bleed and bleed and bleed. Now, one of the telltale signs, if you get out of the hospital and you're still bleeding a lot, is actually that your milk supply doesn't come in. So as long as the placenta is attached to the uterine wall, it's sending out hormonal signals that you are still pregnant. So every bit of this placenta has to come out in order for your body to understand that you are no longer pregnant. If a little piece is in, your body will still think you're pregnant. And because you're still pregnant, you're not supposed to make breast milk. And therefore, the hormonal process of making breast milk doesn't start. So a lot of moms will report that they are bleeding heavy, they're pumping, they're latching, they're doing everything right. Every expert has helped them. They're doing herbs and all this other stuff, and nothing's working. It's usually a good indication there's some placenta there. How do we deal with that? We have to go in and do what's called a dilation and curettage, a DNC. We open up the cervix and we scrape out the uterine lining, and that's enough to get rid of that piece of placenta. A transvaginal ultrasound, which is an ultrasound that's done via the vagina, can sometimes see that piece of placenta, giving us an idea that we need to go ahead and do that. So that's ultimately what needs to happen with this mom. That's the appropriate line of action, in my opinion. And that's what they're probably looking for. I had a question about breastfeeding while pregnant. Thank you so much for taking the time to educate us. I'm curious though, is it possible for a baby to know that the mom is carrying another baby inside and then react differently, maybe by losing appetite for other food and instead just wanting to suck more, or even feel rejected because the mom is pregnant without waiting for them to at least grow to a certain age? So I don't think that the baby necessarily senses that you are pregnant at all. What I actually think that is happening is that the milk has turned back into colostrum. So I have a whole video on breastfeeding while you are pregnant. This is something that you can do. It is safe in many ways. You do have to talk to your healthcare provider. If you're a high-risk pregnancy, this may not work for you. But it is a very legit thing that a lot of people do. And what happens though is when you're pregnant at a certain point in time, the body, even though you've been fully breastfeeding, will turn back into colostrum for the new baby, because a brand new newborn does need to have a little bit of colostrum first. So what we do is that the body will kick back into that. When that happens, the baby that's breastfeeding still is going to be hungry. For those of you guys who read about breastfeeding, you know, colostrum is a little teeny tiny amount because a newborn stomach is really, really small. So if a baby's been eating 5 ounces at the breast and now there's 10 cc's of colostrum, that is not going to feed or satisfy a baby. And therefore, they're going to be irritable. They're going to want to suck more. They're going to do all this other stuff. So I don't actually think it has anything to do with the emotional components of that. It's just simply that the milk has probably changed into colostrum. I had a question about sex. I love talking about sex in my sex video. I am 7 weeks pregnant while having sex with my husband. He says I'm too hot and he stops having sex because of this hotness. Is it normal to be hot? So, I am going to tell you that I am not exactly sure what he is referring to. So your body does run a little bit warmer when you are pregnant, usually, because you are now, you have a much higher blood flow than you had before you were pregnant. Our blood flow increases significantly while you are pregnant because, you know, the body is trying to provide blood for both you and the baby. So that may be what it is. But ultimately, what I would tell you is I would ask for some more information. If he is actually very uncomfortable with penetration in the vagina and what he's describing is hot, I would ask to go to your OBGYN or your midwife and just get checked out to make sure there's nothing else going on that's like not supposed to be happening. I gave birth 6 months ago, and now I've been trying to get pregnant again for the last 3 months. I have no position results yet. Should I get a vitamin to boost myself up? Yes, I'd make sure you're taking prenatal vitamins, but you may have trouble getting pregnant for another 6 months to a year. So our bodies work best and heal best using baby spacing. So it's actually recommended by the WHO that you do not try to get pregnant again until your first child is 2 years old. This is baby spacing. This is actually the ideal way for a woman's body to heal and be ready for another pregnancy. So I understand from your age earlier why you are trying earlier. However, because your body is naturally looking for that for your health, it may just not kick in with full ovulation or anything until it's been given more time. Now, the other thing is if you are breastfeeding, even if you've gotten a period, breastfeeding may be interfering with you actually ovulating. So that's another thing that you should know. But yes, I mean, I would just do prenatal vitamins. You don't need a special vitamin. I had a question on my superfoods video, which kind of goes actually into like Nancy's asking about how do I make my body healthy? And I talked about this a little bit more. But I had a mom say, can a pregnant mom with PCOS take dairy? What are the other alternatives? So dairy is not preferred for somebody with PCOS. So PCOS usually involves insulin resistance, which means a lower carbohydrate or lower sugar diet is better. It also involves high testosterone. So for many of you who might not be aware, a lot of our foods have hormones in it. Now, I am not going to talk about regular versus organic or anything like that. I'm saying food at its core can have hormones. So, for example, soy is a really high source of estrogen, period. Now, when you get into the more complex stuff, when you're talking about eating certain animal products like dairy products, which are milk from another animal, one of the things you got to understand is that has a whole bunch of hormones in it. Now, this is what I mean. I'm not talking about dairy industry or anything else. When a woman makes milk, she has certain hormones, including prolactin, surging through her body, okay? And so some of that's going into her milk. Cow milk is an animal who is breastfeeding, and that's the breast milk for that baby cow. I'm very pro formula, so this is not a knock against formula, guys. But the reason why we talk about breastfeeding being best for babies is because it's human milk for a human baby. When you're drinking cow's milk, if you're not pregnant or anything else, you are ingesting the hormones from that cow. That's how we get it. It's the same process as a human being making breast milk, okay? So when you have PCOS, the dairy products with all those hormones can actually really not be very great for that PCOS mom. So there has been a lot of studies that show that when you limit dairy, when you have PCOS, you can have weight loss, improved insulin sensitivity, and reduced testosterone. So it would be better. Now, what are the alternatives? I mean, it depends on what you're trying to replace. If you're talking about protein, stick with, meats, right? If you're talking about fat, go with, olives and olive oil and maybe butters and stuff like that. So it really depends on what you're trying to replace. I'm down to my last 2 questions. We're finishing up, and then I'm going to tell you guys what tomorrow's video is going to be. I'm 38 weeks pregnant, and my internal exam shows 2 centimeters dilated, 50% effaced, and -3 station, which we talked about all of those numbers. I've lost my mucus plug, but I've had no contractions. Is this normal? Does this mean labor is near, or will I have to wait a week or more? The answer is, who knows? So there are women who walk around 3 or 4 centimeters dilated with their mucus plug long since gone and there's no contractions. Unfortunately, labor is not necessarily predictable. It is sometimes random. So if we could predict it, it would be a lot easier. What I can tell you is take a look at some of my videos on like natural ways to induce labor and check with your OBGYN or your midwife and see if you are allowed to do some of those. But you can be even more dilated than that, and you still might not have the baby for 2 more weeks. Last week I put out a tummy time video, and I had somebody ask, which was such a great question. Once the cord has fallen off and I start tummy time, how many minutes do I have to wait after I breastfeed? What a brilliant question. And I am going to tell you, I would just say breastfeed or formula feed, right? So if you have the cord, right, she's talking about the umbilical cord. This is at the belly button. And this is this little dried up piece of cord that has to come off on its own. So it can be a little uncomfortable to put a baby on top of that. But once that comes off, tummy time can really start very effectively. So the thing is, you're laying on the stomach, so you're compressing that stomach, and babies might spit up. So you actually don't want to do tummy time after they eat. You want to do it beforehand. Now, please check out the tummy time video. There's a lot of stuff. But when you're talking about a newborn in the beginning, you're talking that baby might be tummy time for a minute or 2. You're not talking about 15 minutes or more in the newborn stage. So, you might you wake them up, you change their diaper, make sure they're clean. And then before you go ahead and you start to feed them, however you're feeding them, you lay them down on that clean blanket and you do a little bit of tummy time. Maybe you start by singing them a song, sing them the ABCs or something like that, just to engage with them, let them be on their tummy for a minute or 2, and then pick them up and feed them. So that's how I'd suggest that. But I would definitely, for any of you guys with any tummy time of any age, I don't think tummy time is going to work within 20 or 30 minutes of feeding, because they're most likely going to spit up everywhere. And I have a video on that in case you guys don't know what the difference between spit up and throw up is. Thank you so much for joining me. For those of you who stayed until the end, tomorrow's video is actually going to be on ureaplasma infections. So ureaplasma is a bacteria that can cause a lot of complications for both you and your baby. So please check that out tomorrow. My name is Dr. Samantha. I am the maternity mentor. I am here every Monday at 9 p.m. Eastern Standard Time to answer your questions live. As you can see, a whole bunch of our viewers had a chance to ask questions. I also answer questions from your videos. I really love reading your questions, your comments, all of it. I think it's great. I'm also on Facebook, Instagram, and Twitter for additional content. We will link those into the video description. Please share the channel with your friends and family, your neighbors, your coworkers. Let them know this is a channel that has been certified to be part of YouTube Health. This means I have been vetted. I am a real healthcare provider, and my content is real and something that you hopefully can trust. They've trusted me, so hopefully you'll trust me too. So please share the channel, and please like and subscribe. Subscribing is the key thing for me. As a content creator, I cannot tell you how much it helps us to stay on when you guys subscribe. So whenever you can, please subscribe, and then you can hit that notification bell so you can be notified whenever our latest videos come out, like tomorrow's video on ureaplasma. Thank you so much for joining me. My name is Dr. Samantha. I am the maternity mentor. Have a wonderful evening. Bye for now.